Welcome to the deep dive. Today, we're getting into something incredibly precise, almost microscopic in its demands.
hmm
We're talking about endoscopic injections, the drugs, sure, but maybe even more importantly, the techniques, the safety, the pharmacology behind putting substances inside the body with a scope.
Right. And for this, we're leaning entirely on a fantastic resource, Dr. Raju's YouTube video. It's called HCC 1472 10A Endoscopy Technology Theory Pharmacology Injections. It's really comprehensive.
It really is. And what struck me diving into this is how much safety hinges on, well, the mechanics, the prep. It's not just about knowing what drug to use, but the whole process of getting it ready. That seems to be the first huge line of defense.
Absolutely. It starts right with the equipment. The needles themselves are tiny, 23 to 25 gauge, very fine.
Okay.
But the key concept Dr. Raju highlights is this thing called dead space.
Dead space.
Yeah.
Right. Explain that a bit.
Yeah, so it's basically the internal volume of the needle and the catheter combined. It's empty space, typically holds about 1.5 to 2 cubic centimeters or cc's.
Yeah. And why does that matter so much? If it's empty, it's empty.
Well, no, because if you don't fill that space first with the substance you intend to inject, like epinephrine or dye or glue, what are you injecting instead?
Air. You're pushing 1.5 to 2 cc's of air into the patient first.
Exactly, which can be disastrous. So the priming process isn't just a suggestion, it's fundamental.
Okay, so walk us through that priming ritual. What are the steps?
It's methodical. First, obviously, you fill the syringe with whatever you're using.
Got it.
Step 2, critically, hold the syringe pointing up. Then you slowly push the plunger to get rid of any visible air bubbles in the syringe itself.
Okay, clears the syringe.
Then step 3, you connect the syringe to the catheter and you push the plunger until you see a few drops actually come out the very tip of the needle.
Yep.
That takes about, 1.5 to 2 cc's.
And that fills the dead space we talked about?
Precisely. Now the system is full of the intended substance, not air. But there's one more crucial safety step right after this.
Which?
Immediately turn the syringe so it's facing down. Hold it downwards.
Why downwards?
It's pure physics, really.
Yeah.
If, despite your best efforts, a tiny air bubble somehow remained or formed, holding the syringe down means that bubble will float up towards the plunger, away from the exit.
So if you accidentally push the plunger a little, you wouldn't inject that stray bubble.
Exactly. It prevents injecting air, prevents creating what the source calls an air blood, which is essentially an air embolism. Simple, mechanical fail-safe.
That level of detail in just the setup is pretty incredible. Okay, so the system is primed, bubble-free, pointing down. Now let's talk about the chemicals themselves, especially for controlling bleeding. Epinephrine is the classic one, right?
Yeah, epi is often the first line for active bleeding, especially arterial bleeding like you see with ulcers.
And how does it work? What's the mechanism?
It causes vasospasm. Basically, it clamps down the blood vessels chemically, constricts them very quickly.
And the technique for injecting it, is it just flooding the area?
Oh no, it's quite specific. Usually diluted, maybe 1 in 10,000 concentration for a bad arterial bleed, sometimes more dilute, like 1 in 100,000 for other uses. You inject small amounts, like 1 to 2 cc's at a time, right around and very close to the bleeding vessel.
Okay.
This does two things. The fluid itself puts physical pressure on the vessel that's tamponade, and the drug causes the spasm. You might end up using a total of 5, 10, maybe even up to 20 or 25 milliliter, but it's done in those small targeted injections.
But you mentioned vasospasm is temporary. The vessel's going to open back up eventually.
Correct, and this is a critical point from the source material. Epinephrine buys you time, it stops the immediate gush, but it's not a permanent fix. The vessel will relax and potentially rebleed.
So what's the mandatory next step?
You have to follow up immediately with a definitive thermal method, cautery, using a heater probe or a bipolar probe, something to actually physically seal the vessel shut. Epi stops the crisis, cautery prevents recurrence.
That interplay is key. Chemical quick fix, physical permanent solution. Okay, so that's arterial bleeding. What about venous bleeding, like from esophageal varices? Epi doesn't work as well there.
Right. Veins don't respond to vasospasm the same way. So for venous bleeds, especially varices, you often use a sclerosant, like sodium tetrahedral sulfate.
A sclerosant, what does that do?
It's an irritant, essentially. It damages the lining of the vein, causing inflammation and then scarring sclerosis. That scarring process closes the vein off.
And the technique, similar injection.
Similar in that you inject small amounts, 1 to 2 cc's, often directly into the varix or right beside it. You'd usually start near the GE junction, the gastroesophageal junction. But there's a crucial communication protocol here.
What's that?
Because these agents have risks and dosage limits, the person injecting must announce loudly, clearly, every single time they inject. 1 cc injected, 2 cc's injected.
So everyone in the room knows exactly how much has gone in.
Exactly. Total awareness.
Yeah.
And that becomes even more critical when you talk about the next option for some venous bleeds, especially those big gastric varices, which is glue.
Glue, like actual glue.
Medical-grade cyanoacrylate glue, yes.
Mm-hmm.
It works by causing instant thrombosis or clotting. It solidifies very quickly on contact with blood.
That sounds high stakes.
Extremely high stakes. The source emphasizes this heavily. You have to inject it very slowly, in tiny amounts. If you push too much too fast, that glue can travel upstream
Upstream where?
into the general circulation. It could reach the lungs or even the brain, causing a massive clot, an embolism, potentially fatal. So that loud volume announcement, absolutely non-negotiable with glue.
Wow. Okay. So moving away from stopping active bleeding, let's talk about tools for seeing things better or marking things for later. Dyes like methylene blue.
Right. Methylene blue or indigo carmine, these are used for endoscopy. They stain the submucosa, the layer just beneath the surface lining.
And what's the purpose of staining that layer?
Couple of things. It can help highlight subtle polyps or abnormal tissue that might blend in otherwise. And it's really crucial during procedures like EMR, endoscopic mucosal resection.
EMR, that's removing superficial cancers or large polyps, right?
Exactly. You inject the dye mixed with saline under the polyp or lesion you want to remove. This does two things. It lifts the lesion up, creating a cushion between it and the deeper muscle layer, making it safer to resect.
Creates a safety buffer.
Yes. And second, the blue dye stains that cushion. So as you're cutting the lesion off, if you see that nice blue woolly material, as Dr. Raju calls it, at the base,
That's a good sign.
that's a very good sign. It means you're still in that lifted submucosal layer. You haven't cut too deep into the muscle wall, which would risk perforation. The blue tells you you're in the safe zone.
Okay. And getting that initial injection right to create the cushion involves that technique you mentioned earlier, the tap-tap.
Yes. The tap-tap is vital for EMR injections. When the endoscopist positions the needle and asks for the injection, the assistant doesn't just push the whole syringe. They start with gentle, tiny taps on the plunger. Tap, tap.
Why the taps?
It ensures only a very small amount goes in initially. You watch for the immediate sign of the tissue lifting, forming that bleb or cushion. It confirms your needle is actually in the submucosa, not pushed all the way through.
Ah, it's a diagnostic check during the injection.
Precisely. Because if you just injected, say, 5 cc's forcefully, and that polyp doesn't lift, the source warns your needle's probably gone straight through the wall into the abdominal cavity. Big problem. The tap-tap prevents that by confirming placement first.
Makes sense. Okay, so dyes help with removal. What about marking a spot for the future? Like finding a small polyp again later, or for a surgeon. That's where tattoos come in.
Exactly. Using sterile carbon particle suspension, basically ink. You inject it to create a permanent mark.
Where do you place the tattoo relative to the lesion?
Key rule: never in the lesion itself or even right next to it. You mark about 3 centimeters away. On the distal side, the side further down the GI tract, sometimes called the anal side. Usually 1 or 2 spots are enough for follow-up endoscopy.
And for surgery.
If it's marking for surgery, you typically place tattoos in 3 or 4 quadrants around the lesion, again, a few centimeters away, so the surgeon looking at the outside of the bowel can easily see the marked zone.
Is there a risk of injecting the tattoo ink through the wall, like with the dye?
Yes, same risk. So there's a specific safety technique. You don't just stick the needle in and inject tattoo ink. First, you create a small bleb using saline, just like for EMR, a few centimeters away from the lesion.
Create the cushion first.
Right. Confirm you're in the submucosa with that saline lift. Then, you inject the tattoo ink into that existing saline bleb. It keeps the ink contained within the bowel wall layers.
Very clever. Okay, one last substance mentioned is Botox, botulinum toxin, used endoscopically.
Yeah, not just cosmetic. Endoscopically, its muscle paralyzing effect is used mainly for 2 things: relieving the spasm of the lower esophageal sphincter and achalasia.
That's where swallowing is difficult because the sphincter won't relax.
Correct. And also sometimes injected around chronic anal fissures to relax the anal sphincter muscle, which helps the fissure heal by improving blood flow.
And the dosing for achalasia?
Typically around 100 units total, usually diluted into 4 or 5 cc's of saline. Then you inject 25 units into each of the 4 quadrants of that tight lower esophageal sphincter.
Is it a permanent fix?
No, definitely not for achalasia. The effect is temporary, lasts maybe 6 to 9 months, sometimes a bit longer. So patients often need repeat injections.
Okay. So, we've covered a lot of ground bleeding, marking, spasm relief. If we boil it all down, what are the absolute core safety principles that run through all these injection types?
Looking back across everything in the source, three things really stand out as non-negotiable. First, keep that syringe facing down after priming. Always. Protect against air.
Got it. Number one, no air.
Number two, prime the needle properly. Make sure the dead space is filled, no bubbles. And related to that, number three, communicate. Announce the volume injected, especially for risky stuff like sclerosants or glue. And use that tap-tap technique for submucosal injections like EMR or tattooing to confirm placement before giving the full dose.
So, no air, prime properly, communicate volume, and confirm placement with the tap-tap.
That really seems to be the essence of the safety protocols distilled from Dr. Raju's material.
It's quite something. We went from stopping massive bleeds, using vasospasm, all the way to the delicate tap-tap for lifting tissue and marking spots with ink safely. You really get a sense for the incredible precision required.
Yeah, the level of detail, the thinking behind every single step to ensure patient safety, it's impressive. Every action has a potential consequence that's been thought through.
It really is. And it leaves you with a final thought, maybe for you listening. We talked about epinephrine needing that immediate follow-up with cautery, that tension between the quick chemical fix and the necessary durable repair. How does that dynamic, that need to instantly commit to a second, more permanent step after the first intervention, shape the mindset needed for endoscopic emergencies? What happens philosophically almost when the quick fix demands an immediate, irreversible follow-through? Something to ponder.
Definitely food for thought.
Until our next deep dive.